Every surgical intervention in the stomach demands a strict physical exchange. Removing a tumor forces a permanent, engineered alteration of the body's digestive mechanics. In normal baseline physiology, digestion relies on an orchestrated, one-way fluid dynamic. Food passes straight down the esophagus, mixes with acid in the gastric reservoir, and then encounters a precise metering of biliary and pancreatic juices in the duodenum. Eradicating severe gastroduodenal pathology requires severing this sequence. This diagram displays the Roux-en-Y reconstruction, illustrating the extreme lengths required to bypass the stomach entirely. The natural digestive pathway is stripped away and replaced with a completely artificial geometry. The clinical challenges patients face years after these operations are highly predictable, physical consequences of their newly constructed anatomical plumbing. When an ulcer perforates the duodenal or gastric wall, it triggers sudden onset peritonitis. In these acute urgencies, optimal anatomical reconstruction is secondary to immediate survival. The surgeon performs a thorough peritoneal toilet to clear the abdominal cavity of debris. For a duodenal tear, the defect is closed transversely and reinforced with a patch of omentum. Gastric perforations carry an additional risk. They must be physically excised and closed to permit a histological biopsy, definitively ruling out an underlying malignancy. Massive bleeding requires a different open damage control tactic. When endoscopic control fails on a spurting visible vessel, frequently the gastroduodenal artery, surgeons must expose the bleed directly. The duodenal is fully mobilized and incised longitudinally, exposing the bleeding vessel for underrunning sutures. To prevent a stricture, the Heinecke-Mikulich principle is applied. The vertical incision is closed transversely, functioning as a pyloroplasty to widen the anatomical lumen. In catastrophic hemorrhages, the native architectural integrity of the GI tract is temporarily compromised to achieve immediate hemostasis and control sepsis. Before the invention of proton pump inhibitors, intractable peptic ulcers were treated mechanically. Surgeons physically disabled the body's acid factory. A truncal vagotomy accomplishes this by severing the vagal nerves, cutting maximum acid output in half. Because this denervation causes severe gastric stasis, it mandates an accompanying drainage procedure to empty the paralyzed stomach. The alternative was removing the acid-producing tissue directly. In a partial gastrectomy, the distal portion of the stomach, the antrum, is completely excised. In a Billroth 1 reconstruction, the distal stomach is removed, and the upper stomach is anastomosed directly to the duodenum. This preserves a largely linear flow. Food travels down the standard anatomical path, maintaining easy endoscopic access to the ampulla of Vater. A Billroth 2 reconstruction alters flow completely. The duodenal stump is closed off, and the remaining stomach is anastomosed directly to the jejunum. Bile and pancreatic juice must travel from the blind duodenal stump to merge with food inside the jejunum. Losing the pylorus and the distal stomach subjects the patient to a cascade of mechanical failures. The lack of a metering valve leads to rapid osmotic loading in the intestine, known as dumping syndrome, alongside intractable bile vomiting, iron deficiency anemia, and metabolic bone disease. While the Billroth procedures effectively cured the targeted ulcers, their geometry permanently sabotaged the body's natural digestive pacing. Proximal and mid-stomach gastric cancers require a much wider clearance. A partial excision is insufficient. Oncological protocol demands a radical total gastrectomy. The surgeon removes the entire stomach and the omentum en bloc, taking a 5-centimeter clearance margin on the esophagus and clearing the surrounding arterial lymph nodes. This diagram illustrates the reconstructive challenge. Without a stomach to act as a reservoir, the esophagus must be bridged directly to the small intestine. The surgeon creates an alimentary jejunan rouleum. By anatomical requirement, this intestinal loop must be at least 50 centimeters long. This specific length leverages gravity. It provides the physical distance necessary to prevent caustic bile from refluxing into the unprotected esophagus. Down below, at the Y junction, the biliary limb completes the circuit, reintroducing digestive juices back into the newly constructed main tract. Operating on this scale carries immediate risk. The multiple suture lines introduce the potential for catastrophic esophago-jejunal leaks, duodenal stump blowouts, and biliary peritonitis. A total gastrectomy ensures maximum oncological clearance. In exchange, the complete removal of the stomach strips the body of intrinsic factor, ensuring a permanent vitamin B12 deficiency. Surgical intervention does not always require resection. When a malignant mass causes a gastric outlet obstruction, the primary goal shifts to palliative flow management. A gastroenterostomy creates an isoperistaltic bypass, routing food away from the blocked antrum and dumping it directly into the first jejunal loop. But mechanical twisting presents a completely different threat. In a gastric volvulus, the stomach physically rotates on an organoaxial or mesenteroaxial plane, cutting off its own blood supply. The stomach is untwisted laparoscopically. The surgeon closes any associated diaphragmatic defects and performs an anterior gastropexy, physically suturing the stomach to the abdominal wall so it cannot twist again. In the specific case of massive, unyielding blockages, like large trichobezoars that defeat endoscopic tools, surgeons must bypass the normal tract entirely, choosing to cut directly into the organ itself for a manual, open extraction. Leaving the tissue intact does not leave the mechanics intact. Bypassing the stomach's exit or anchoring its outer wall inherently restricts its native motility. For a modern gastroenterologist, a patient arriving with a history of undefined gastric surgery requires immediate forensic analysis. The standard anatomical map is obsolete. Depending on the exact surgical history, reaching a target like the ampulla of Vater shifts from a routine procedure into a labyrinthine dead end. Every complication a patient faces, from an immediate postoperative leak to the 10-year lag phase for malignant transformation, is dictated strictly by the blueprint the surgeon left behind. Mastering gastroduodenal pathology requires approaching the gastrointestinal tract as a highly calibrated fluid dynamic system. Resecting the disease is only half the operation. The rest is managing the physics of the reconstruction.